In modern surgery, before any of the really intricate work can begin, it all hinges on one critical moment: gaining access. It is the very first step, and honestly, in a lot of ways, it's the most important. Today, we're going to break down exactly how surgeons pull it off. And that's the big question, right? This is the whole magic of minimally invasive surgery. Instead of one big opening, surgeons use these tiny little keyholes. So how do they safely create those entry points and, get enough room to actually do the surgery? That's the fundamental puzzle we're going to solve. All right, so let's dive right into the core challenge here. Gaining access is the very first thing a surgeon does, and it's a moment where precision is absolutely everything. I mean, a mistake right at the beginning, a blind poke that goes wrong, that could damage a major blood vessel or an organ before the real surgery even gets started. The stakes are incredibly high. So when you boil it all down, every single tool, every technique we're about to talk about, it's all laser focused on one thing: creating a safe doorway into the abdomen. You nailed this part, and you've set the stage for a successful operation. Okay, so you've got a pathway in. Now what? Well, you need space. Think about it. The abdominal cavity isn't just an empty box. It's normally a collapsed space, with all the organs kind of resting against each other. So to do anything, a surgeon has to create an open, stable environment. Let's get into how they do that. And here it is, the magic word: pneumoperitoneum. It sounds complicated, but it's the technical term for gently inflating the abdomen with carbon dioxide gas. And what that does is lift the abdominal wall up and away from the organs underneath. And just like that, you've got your workspace. Honestly, the best way to picture this is to think of a collapsed tent, right? You can't do anything inside. It's impossible. By pumping in that CO2, the surgeon is basically putting up the tent poles, creating this nice, stable dome they can work under. It's a super simple but brilliant idea. So this whole process of creating the workspace, it really just comes down to two main moves. First, you insufflate, that's the fancy word for pumping in the gas, to create that dome. And second, you place the ports. These are the hollow tubes that act as the gateways for the camera and all the instruments. Now this is where it gets really interesting. How a surgeon actually does that very first step leads to these two major, almost philosophical approaches to entry. And let me tell you, this is the kind of debate you hear surgeons having at every single medical conference. It's a classic. So on one side, you've got what's called the closed technique. This is where you do a blind but very, very controlled puncture with a special needle to inflate the abdomen first. Then, on the other side, you have the open technique. Here, the surgeon makes a small cut and puts the first port in under direct vision, watching every single layer as they go. So, blind versus direct vision. That's really the heart of the debate. And look, these two philosophies aren't just, abstract concepts. They depend on completely different toolkits. So let's take a look at the actual instruments that make each of these techniques work. All right, for the closed technique, the absolute workhorse is the Varese needle. This thing might look simple, but it is a genius piece of engineering. Its entire design is all about one thing: safely poking through the abdominal wall to start pumping in that gas before any bigger instrument gets anywhere near the patient. The design is just so clever. It's got this sharp outer sleeve that pierces the tissue, but on the inside, there's a blunt, spring-loaded tip. So the second it breaks through into the open space of the abdomen, pop, that blunt tip springs forward, shielding the organs from getting nicked. But even with that, surgeons are super careful. They'll run these little confirmation tests, like a saline drop test, just to be 100% sure they're in the right spot before a single puff of gas goes in. All right, so the tent is up, the pneumoperitoneum is good to go. Now it's time to place the ports. And for that, you use a trocar and cannula assembly. Just think of it this way: the trocar is the sharp, or sometimes blunt part that creates the tunnel, and the cannula is the hollow tube that stays behind. That's the gateway for your instruments. But here's the thing: not all trocars are created equal, and the choice of the tip is a classic trade-off between risk and reward. First up, you've got your bladed trocars. They have a sharp, cutting tip. They make entries super easy, but they also carry the highest risk of injuring something on the inside. Then you have the bladeless ones. These have more of a cone-shaped tip that splits tissue fibers apart instead of cutting them. It's a lot safer, but you definitely have to push a bit harder. And finally, you have the really cool ones, optical trocars. They have a tiny camera built right into the tip, so the surgeon can literally watch each layer of tissue as they pass through. Slower, for sure, but you can't beat that visibility. Okay, so let's switch gears to that totally different philosophy, the open technique. For this, you need a different tool. And that tool is the Hasson cannula. Since the whole point here is entering under direct vision, it has a blunt tip, no need for anything sharp, and it's designed to be stitched right into place to create that all-important airtight seal. And this begs a really practical question, right? If the closed technique is usually faster, why would a surgeon ever choose the more deliberate, open approach? Well, the answer is all about managing risk for certain patients. A surgeon is almost always going to lean towards an open approach if the patient has had abdominal surgery before. And why is that? Well, previous surgeries can create scar tissue, what doctors call adhesions. And that scar tissue can basically glue the bowel right up against the abdominal wall, exactly where you're trying to enter. So the open technique lets the surgeon carefully dissect through that area while watching everything they're doing, which just massively drops the risk of a catastrophic injury. So it doesn't matter if you're going open or closed, using a Varese needle or a Hasson cannula. There are a few universal principles, they're really the golden rules, that every surgeon follows for a safe entry every single time. First and foremost, pressure. That insufflation pressure inside the abdomen has to be watched like a hawk. It's usually kept right between 12 and 15 millimeters of mercury. If it's too low, your workspace collapses. But if it gets too high, it can actually interfere with the patient's breathing and their circulation. So that number is on the screen and monitored constantly throughout the entire procedure. And finally, safety isn't a one-and-done thing. It's this active, ongoing process. It means choosing the anatomically safest spot to go in, which is usually right below the belly button. It means always double and triple checking where your needle or trocar is. And crucially, it means tailoring your technique to the patient in front of you, thinking about things like obesity or, as we just talked about, that history of prior surgeries. So, while we're often blown away by the really complex, intricate parts of an operation, it's this mastery of simply getting inside that makes everything else possible. A safe start is the absolute foundation for a good outcome. It just goes to show that in surgery, what looks like the simplest step is often the most critical one of all. And it really makes you wonder, as technology gets better and better, will this first step ever be completely automated, or will it always need that hands-on human judgment of a surgeon?